Okay. Let's get started. What we're going to do, so tonight we're covering healthcare. There's going to be three of us are going to speak briefly. I'm going to do some historical background. Damiano is going to talk about the Affordable Care Act, and Dr. Miller-Meeks, the director of the Iowa Department of Public Health, is going to talk about some of the implementation issues at the state level. And Pete will do a more formal introduction of our guest just before she speaks. So let me start by just giving you a very sort of spare historical overview of how we got here, of previous episodes at health reform. There are these 7 episodes in which some form of health reform is debated and some form, in most cases, is passed. And as you'll see, this corresponds very closely to the sort of epochs or regimes of policy that we talked about near the beginning of class, the sort of characteristic moments of political innovation. The first of these occurred in the progressive era, when there was a push by social reformers for what was known at the time as working man's insurance or social insurance. It wasn't really what we call today health insurance, because it only provided coverage of wages that you lost due to sickness. Because it didn't pay for your health care, it just paid for, it filled in your wages when you were sick. This lives on today in the form of AFLAC, right? That's the indemnity insurance. This came at a time, of course, when, as we've seen, federal authority is pretty thin. Most of the innovation is done at the states. States are leery of doing things on their own. And for a variety of reasons, partly opposition from the insurance industry, the fledgling insurance industry, and partly the outbreak of World War I, which sort of puts a damper on policy options that are portrayed at the time as Prussian or German inventions, really sort of bring that moment of reform to a halt. One of the interesting things about this moment, just before World War I, is that one of the most diehard proponents of reform were doctors. Doctors at the time were not very well-paid professionals, and they saw social insurance as a way of sort of girding their incomes and their professional status. But it comes to nothing. This comes back on the agenda during the response to the Depression, during the New Deal, and in the course of drafting and crafting the Social Security Act in 1935, the Roosevelt administration gives considerable attention to the prospect of some form of health insurance as well, that would sort of look like the old age and the disability titles of Social Security. But again, it runs into problems, one of which is that the New Deal cannot get its head around how they would pay for health care. Because all the other elements of the Social Security Act, particularly the old, or not all of them, but the core of the Social Security Act, particularly the pension system, is paid for on a contributory basis, right? You pay in during your working life and you get it out when you retire. But there was a considerable worry in the administration that healthcare didn't have that kind of logic to it. It was a sort of square peg in a round hole. There was no guarantee that those who paid into the system would ever get anything out of them, because they might not get sick. And then those who got very sick would take out more than they put in. So it didn't fit that sort of financing model. And more seriously, as the cartoon up here suggests, Southerners in the New Deal coalition opposed to these sorts of general or universal benefits paid for out of general revenue taxes, because it meant equal benefits for African Americans in the South, and it violated the premises of Jim Crow. So particularly late in the New Deal, Southerners were really digging in their heels against federal spending, not only on insurance, but even on public health. There's a lot of expansion, a lot of change occurs during World War II, the principal innovation of which is in response to wartime price controls and wage controls, many companies, with the blessing of the federal government, begin experimenting with job-based health benefits. this was really the origins of the American system of organizing healthcare through the workplace. It was a way of evading those World War II restrictions. But many New Dealers, through the war years, held on to the idea that they would be able to add national health insurance to the Social Security system when the war ended. In fact, there's a big push beginning in 1946 and culminating in 1948 for a full-blown system of national health insurance. This doesn't go very far for a couple of reasons. First of all, the American Medical Association, which is now opposed to this kind of reform, really digs in its heels, and in the process basically invents the modern art of political lobbying, creating one of the very first political action committees, levying a tax of $25 on all of their members, raising a war chest, and just blitzing the debate with their opposition, including this infamous comic book, The Sad Case of Waiting Room Willie, which told the story of a poor patient who went to see a doctor, but of course couldn't see the doctor because all the people getting free health care were lined up ahead of him. And what emerges out of this debate, this is also, of course, it takes place in a Cold War context, and so just as the World War I effort sort of foundered on the rocks of that foreign policy issue, in 1948 it's very difficult to have an intelligent discussion of a national healthcare system which is found, after all, mostly in Europe and also in the Soviet Union. And what emerges as an alternative are forms of voluntary health insurance, particularly job-based health insurance. That system that was invented during the war really takes off in post-war collective bargaining. This is, again, the peak of the union movement, so you got roughly 40% of private sector workers belong to unions, and they're winning health benefits at work. And that becomes the foundation for the post-war healthcare system. The issue next comes up during the Great Society in the early 1960s, when there's another push to sort of round out that system. It's a more sort of discrete and discretionary proposal. The recognition is, come the early 1960s, the job-based insurance is growing. Those that are left behind are those that fall out of the labor market, either because they're too poor or because they've retired. And so you again get in the debate, get this sort of tirades against socialized medicine. But Medicare and Medicaid have passed in 1965, largely with the blessing of hospitals and doctors who see it as sort of increasing their patient and consumer base. And again, largely because they don't compete with the system of employment-based provision, but they mop up around it. They pick up the retirees, and they pick up those who are too poor or too marginal to the labor market to get coverage to work. Following or through this period, the scope of job-based benefits grows fairly dramatically. What's really added to the mix is full coverage of the actual cost of medical care, gradually displacing that earlier indemnity coverage, and gradually rolling family members in as well. So by the early 1970s, certainly almost all unionized workers and many workers in the economy, roughly 70%, have job-based health insurance for which they pay very little, and it covers themselves and their families. But that's about the peak of the job-based system. Things begin to go south after that. So this graph, for example, shows just basic hospitalization insurance. You can see through 1972, that's the peak for hospitalization, about 86% covered, and then it begins to fall off and continues to fall off to the present day. And as you can see by the colored line, this is a mix of Blue Cross Blue Shield, private group insurance, with the red line showing the percentage that are covered by private hospital insurance. It's also a system that varies considerably depending on where you are in the labor market. So high-wage workers get coverage of about 90%. Middle wage, right at the median, get coverage about 75 that fallen to about 65 today, and low-wage workers never have much coverage. So it's a very uneven system of provision, which really remains a fundamental problem. Into the 1970s and 1980s, the biggest problem that stems from this is the rapid increase in the cost of healthcare, particularly to employers. So much of the attention shifts from providing coverage to more people to cutting the costs that are falling on employers as a result of the job-based system. And certainly the most dramatic consequence of the 1972-74 round of reform was the rise of the Health Maintenance Organization as a different way of organizing healthcare. So we have standard fee-for-service taking almost all of the coverage in 1980, but it's only a very small slice of it just 20 years later. The Clinton round of reform basically replays what we saw in the early 1970s. It's yet another effort to sort of patch together some sort of way of maybe expanding employment-based coverage, of mandating that more employers come into the system, giving tax breaks to small business so they do so. But again, of course, famously, it goes nowhere. And it goes nowhere for a number of reasons. But I think more important for our current purposes is just to sort of sketch what problems it leaves behind. There's the fundamental problem of job-based care, the fact that low-wage workers are not getting coverage and increasingly high-wage workers can't afford the coverage that they're getting. There's the fact that rates of insurance are actually falling, and falling most dramatically, as we can see with the red arrows, during periods of recession. You can no longer make the argument that the private market is going to roll in everybody, but in fact the rate of insurance rises steadily, or the rate of uninsurance rises steadily over this period. And the costs are increasing for everybody. They continue to increase for employers, and that's a major problem. But employers push more and more of that cost onto employees in the form of co-payments and deductibles, sort of 80-20, 60-40 plans. And as you can see on this graph, health insurance premiums and workers' contributions to premiums, the orange line, rise faster than anything else in the economy. They rise faster than health insurance premiums, much faster than earnings, and much faster than the overall inflation rate. And this is true across the economy. We see here, this is national healthcare spending per person as a share of the economy from 1960, when it's about $200 and about 1% of gross domestic product, to today, where it's about $8,000 a person per capita in health spending, and approaching 20% of gross domestic product. This puts the U.S. sharply at odds with its peers. So there's the average of the Organization of Economic and Cooperation in Developing Countries. There's 10% of GDP, roughly. And there are the high spenders, and there's the U.S. We spend more in public dollars than most of our peers, and then we spend as much again in private dollars. And of course, through this period, there's a dramatic growing gap between individual coverage and family coverage. One of the reasons why we see a sharp rise in, for example, children's health insurance program coverage at the state level, that is public coverage, is because private coverage or workers in private coverage are covering themselves, but they can't afford to cover their families anymore. So they just elect single coverage and have the state programs cover their kids. Through this period, in the wake of the Clinton reforms, business continues to worry about the cost of healthcare and look for some ways of sort of escaping that cost. And what's interesting about this is that one of the things that business and conservatives in the late 1990s, early 2000s become very interested in is the idea of individual responsibility as an alternative to business responsibility for paying the cost of healthcare. To the point where a lot of prominent conservatives, and we know this in the current campaign, including Mitt Romney, the American Enterprise Institute, and Newt Gingrich, favor an individual mandate as a solution to the healthcare problem. If everybody has to carry health insurance like they do car insurance, you'll pool the risk and enable a bunch of other reforms. But the problems remain really overwhelming. This leads us to the most current round of reform, the Affordable Care Act, which was passed in 2009. This graph, the blue squares of this graph are countries. There's like 163 countries on this graph. And as you go up the vertical axis, this is life expectancy at birth. And then as you go out the horizontal axis, this is per capita health spending. So you can see, as you spend more, generally speaking, you get better results, right? But most of the action is over here, right? So you have, Bolivia, which doesn't spend much money on healthcare and gets life expectancy of about 62 years. You get Cuba, which, is up there at 80 years life expectancy, don't spend much more. Finland, Canada, and of course, you can guess where the U.S. is. Way out there in terms of per capita spending, but we're not getting any better outcomes, at least on this measure, than those that are spending, in many instances, half as much. So when we get to the most recent round of reform, and people talk about the details of this, I think we see a number of sort of lingering vestiges of that long historical debate in the lead up to the Affordable Care Act, and indeed in the debate, often contentious debate that follows it. And that would include the sort of lingering confusion as to what the place of employment-based care is in our healthcare system. There remains this conviction, I think, that that's the core of the system, and all we need to do is mop up around it, make sure small businesses are able to provide care, make sure that bigger businesses continue to provide care. But as we've seen, the costs are rising, the rates of coverage are falling, and the rates of coverage are falling dramatically for employment-sponsored coverage of entire families. So that remains a real problem. There are also, and this is sort of clear echoes back to the 1930s and 40s, consistent sort of ideological, intellectual, and ethical issues involved, whether people are paying for something or getting something they didn't pay for, or paying for something that they're not going to get. So it violates that sort of basic American premise of having an identifiable tax or contribution that comes back to you as an identifiable benefit. And of course, this leads into the sort of backlash against the very idea of government-sponsored care. The most ludicrous expression of which was the signs, get the government's hands off my Medicare. Medicare is a government program. But I think, people feel that way because of the way it's financed, because it's financed by their contributions. They see it as an insurance program that they paid into and not a tax and spend government program. We see again, the persistent problem of professional opposition, although I think we've moved a long way from the 1940s when the AMA was dramatically opposed to any form of reform. In fact, there are many basic elements of the Affordable Care Act which hospitals and doctors, including organized doctors, are in favor of. But there's always the leeriness of sort of bureaucratic control over professional autonomy. We also see the sort of lingering sense that having the government provide something is not the most efficient way to do it. Although in the case of healthcare, this really flies in the face of the facts, because the most efficient elements of our healthcare system are Medicare and Medicaid in terms of what they spend on administrative costs. And of course, all of this occurred in the context of our worst national recession since the 1930s. There's a worry about what it's going to cost. And so, in one sense, you have this view that, there's a catastrophe awaiting us when this thing goes online. But of course, the background catastrophe is we're always spending all that money and not getting much for it. And with that, I'll turn it over to Pete, who will talk about some of what was accomplished in 2008.
Thank you, Colin. I think that was a great segue into talking about the Affordable Care Act. The official name is the Patient Protection and Affordable Care Act, PPAC. The bill was really written much more from the congressional perspective than the administrative perspective. And you had, for the first time in a while, Democrats in Congress, in the House and the Senate, they had this feeling that they wanted to accomplish something, and so that's where the bills came from. And one of the big differences, I think, between this time around and the Clinton years is the Clinton approach was very much a top-down approach. The administration got these panels together. They did it much more in private and sort of in secret. They were trying to keep the special interests out, they said, by doing that, but by doing that, they didn't engage the Congress very effectively. And so you had like 13 different committees in the House that all were working on some other piece of the legislation that was going through. And you had, because of that, a huge spectrum of plans that were on the table. And so on the far left, you had everything from what would be the equivalent of the national health system in Great Britain, where you were going to be turning over all of the facilities basically to the government, and all of the healthcare providers would be government employees, and you'd have a national health system. So that would be sort of on the far left. You start moving to the right from there, if you will. The next was a single-payer plan, which would be more similar to what they have at the provincial level in Canada, where you would have a Medicare for all or a national health insurance. So that's just the payment side. The delivery side would still be private. Then you move again towards the middle, like one more step, and this is what the Clinton approach ended up being, and that was a business mandate. So rather than, title slide, sorry. Rather than the individual mandate, you had the onus on businesses. So that's just a slightly left of center approach, if you will, so that the onus was going to be on the businesses to provide it and not on the individual. This approach, the individual mandate, is actually sort of a right of center approach that does go back actually to the early 70s, when people were worried about the government takeover in a single payer or a national health system, which to me isn't even not realistic in any way. The single payer, though, is something that people who either believe it's the panacea or fear that's where we would be going, that single payer option. And so the idea is, how do we keep the private insurance companies in play? And so to do that, that's where the individual mandate is actually being driven by the insurance companies, even though it's talked about a lot as this government takeover. The insurance companies have been criticized, and one of the things we're going to get into that I think is critically important as you understand this, is when you think about this, is that most of the insurance reforms in this are aimed at the individual and small business markets. And I think that's one of the strengths of this, but it's also one of the weaknesses. So if you think about who are the people that have been getting killed, if you will, in the last 20 years in trying to get health insurance, it's the individual that goes out and tries to buy a policy for themselves or for their child, or a small business that's trying to cover 5 or 6 people. And what happens? You get pre-existing condition. We're not going to cover you. It costs a fortune. You get sick in the middle of the year. We're going to drop you, or we're going to jack up your rates. You've got a small business. You have somebody who gets cancer. All of a sudden, that person, you've got to make a decision of firing that person, or you're going to take on the additional costs in a company that usually are marginally profitable, don't have the ability to do that. So, as Colin was talking about, the United States, unlike virtually every other country, we've never, and I think this is a strength and a weakness of the United States as well, we don't do these big steps generally. We tend to do things very incrementally. So we have that employer-based process that started during World War II, but just happened. It didn't happen because we say we're a free market country and this is what we should do. So then where's the gap? Then Medicare and Medicaid came in, cover seniors, cover people with disabilities, eventually cover people in nursing homes, as well as some of the poor. Then who's missing? Well, children of the working poor. Well, we like them. So then the Children's Health Insurance Program came in 1997, so we're covering them. So now this attempt is, okay, now who's left? And that's a lot of the people who are trying to purchase through the individual small business market. Now, whether this is the right approach or not, again, I'm not here trying to say this is a panacea, which it is not, or this is horrible. Again, that's not the approach. But I'd like you to try to be able to break these things apart to sort of, then you can make hopefully a better decision on whether you think this is the right thing or not. But I think it's real important to think about that. And then that plays a lot into the politics of this as well. So, I mean, you can't pretend that this isn't in a political environment that's crazy, right? And so, unfortunately, what most people do is they're going to be, and I think this is true with most complex policy issues, and we've talked about this from the very beginning, this idea that these, whether it's transportation bill or it's Wall Street reform or healthcare reform, they're so complex that people start doing this as they start thinking about it, and then they look to the talking heads, right? They're either going to look to MSNBC or they're going to look to Fox News, and okay, what are people saying, and that's what I'm going to believe. And what I hope this class is doing through the whole semester, if nothing else, is getting you to think about all these issues, whether it's, whatever it might be, tax policy or anything else, just a little bit more critically and try to break it down. But it is hard. I did this presentation somewhere up at the legislature about a month ago, and there was a conservative legislator, Republican from Western Iowa, and he came and talked, and I wasn't sure how he was going to sort of react, even though, again, I'm not trying to take sides. And afterwards, he came out to me and goes, this is great. This is exactly what we need to hear. The people in my caucus, it makes our heads hurt. We just don't think about this in the way that I think we should. Would you come and talk to our caucus? So that's what we're really hoping to be able to get out of this. But it is hard. I'm just going to, real quickly, we're spending, as a country, how many people think A? How many B? How many C? Okay. How many D? Okay. Majority who were willing to take a guess is C. We spend just a little under $3 trillion a year. And as Colin mentioned, that becomes a problem as a proportion of our GDP and all that. And as economists talk about it, it deals with opportunity costs, which is that idea that that's money we could be spending on something else if we're not spending it on healthcare. And so when we're in internationally competitive markets, whether it's cars or whatever else, because we're spending so much more, it really hurts us. And this is just another way of looking at the trend of per capita spending per country over here and health expenditures by GDP over there. And from 1980 on, we are going different. Now, if you really want to get into the outcomes one, which people focus on, we'll look at life expectancy. Well, we don't have time to get into that today. The problem with that relationship is spending on healthcare does not affect life expectancy very much at all. Only about 10% of our health status, and I'm doing this for the benefit of our Director of Public Health who will be coming up, because so much of our health status is based on not clinical care, but things that are more affected by public health. Things like genetics, things like in the environment, things like behavior. That's what affects 90% of our health status. Only about 10% of our health status is actually affected by the amount we spend on our healthcare system. But we kind of have this backwards in terms of where our spending is. And there was an Institute of Medicine report that came out yesterday talking about the value of public health and how while we spend $8,000 per person on clinical care, we spend $250 on public health. And how that, if we're really trying to spend on the things that affect our health status, we're not doing that very effectively. But when you look at the international health comparisons, you got to, again, be careful with the apples and oranges things a little bit. No offense, Colin. So this is what you know. It's part of what's driving this, right? We've got 50 million people in the United States, depending on which number you want to believe, but approximately, that do not have health insurance at any particular point in time. And I think the important thing that was pointed out is that that's grown 13 million just in the last 10 years. And that's because employer costs are going up so much, they're dropping dependent coverage, they're dropping even some for themselves. Their costs, they just can't handle the increase in costs. And those uninsured are not people that are not insured because they're not working. 80% of the uninsured are working people and their families. It just depends on where they work. And so I talk about this, your insurance coverage is based more on where you work than if you work. Some of these people are working 2 and 3 jobs, but they're working in lower wage service sector jobs that don't offer these kinds of benefits. And when 2/3 of them are making less than $50,000 a year, there's no way that you can afford that $13,000 to $15,000 in insurance coverage. So it's not like they're not getting insurance because they're not trying. It's just that there's no possible way. And when you look at the data, there aren't that many people that turn down insurance that could get it in exchange for money or something like that. It's just the types of jobs and the way they tend to be working. And then again, you look at that employer cost. And this is also one of the things, though, when you can this healthcare reform approach that we're taking work, I'm not convinced it can because of these kinds of dollar amounts that we're talking about, but we'll talk about that. So again, the focus of the insurance part, which is mostly what we're going to talk about tonight, is the individual and small business component. Large employers are already self-insured, and we can talk about that later if you want to, but they're really outside of this. But this is also one of the reasons that I think the support for this is lower than it might feel like to some. Well, that healthcare's a winner. If we cover people, it's a great political thing. Healthcare's not a great political thing in general. And on top of it, most of the people who do have power and influence do have good coverage. And so those people that have employer-based insurance aren't really affected by most of what's in this law that much. And so you see all of this political time and effort being spent on something that's for those people. And they don't really get if there's anything in this for them or not. And I think, that's a problem. So you end up with something that feels like this to people. And so that's, President Obama down there saying, maybe I should have been more specific. Well, you could argue he could have been more specific, or any complex policy issue just sort of feels like this and it becomes overwhelming. And it's really tough for policymakers. And as Colin mentioned and as talked about at the beginning, this really is somewhat of right of center, but one of the reasons I think this is both better, if you will, politically, and worse than during the Clinton era, where you had all of these things on the table so that Congress could never get together and was never going to pass anything. But this time, you only had one committee basically in the Senate. You had the Senate Finance Committee, and it was basically 6 senators, 3 Republicans, 3 Democrats. Senator Grassley there for most of the time. They're the ones that wrote the majority of this bill. And then towards the end, the Republicans decided that they weren't getting enough political, whatever you want to say, and they stepped aside. And I've talked with Senator Grassley's aide, who was in the room for a lot of this kind of stuff. And, there was not ever anything sort of from the middle to the left on the table during this discussion, which both made it more likely that they were going to get something through, because you had the 1 Senate committee, you had 3 House committees only, and all 3 in the House agreed that they were going to come together as one bill. So you basically, just for the political science part, you only had 1 Senate bill and 1 House bill, so it was much more likely that Congress could actually pass something. And it never even got to the House side. Everything came from the Senate side, because by that time the politics was such that the House side, which would have pulled the whole bill further to the left, they basically said, forget it, we're not even going to reconcile this. We said we were, forget it, we're not going there. But it allows everything to feel like it's further left, because it was the furthest thing left on the table, if you will, if that makes sense. So the national health system stuff, the single payer stuff, the business mandate, none of that was being discussed this time around like it was the last time. So I think that makes it feel very differently. And ultimately, I think this is just one of the big differences between the 2 parties in terms of health care. The Democrats think this is a really big issue and we need to change something that's really broken. And in general, Republicans don't think it's that bad. That we've got a pretty good healthcare system, maybe we need to tweak here or there, but it's just not that big a deal. So how you approach it, how big of an issue, how much you want to change, it's going to feel differently. So cost was raised. The discussion, and these are Congressional Budget Office numbers. Would I stand behind these numbers? No. We know that every time we look at these major programs, are the estimates ever correct? No, but they're what we have to go on. And the Congressional Budget Office has said basically the cost a little under $1 trillion for the first 10 years, and the impact on the deficit actually is not going to go up. It will actually go down because of some of the combinations of things. Now, some of you might have seen 2 days ago, though, there was a report that came out. It was on the front page of the Washington Post from a conservative member of the Medicare Advisory Committee who reanalyzed these things and said, no, they actually impact, from his perspective, on the deficit. It's going to go up $340 billion. And a lot of it was that they weren't looking at things differently. It had to do with where the money is going to flow. So the Medicare Hospital Trust Fund would actually gain, but as a result, the deficit would go up because of the pots of money that would go into. But in the end, again, are these numbers something that you're going to stand behind? Probably not. But the thing that's interesting, again, about that idea of, is this a government takeover, if you will, or where we're driving people, we're driving more people into the private insurance system through this than into the public insurance system. Again, these are CBO numbers, and it's estimated about this total thing will pick up about 32 million of the 50 million uninsured. About 24 million will get picked up by private insurance through the health insurance exchanges. About 16 million will get picked up primarily through Medicaid, primarily for single adults. And then there'll be a little bit of shifting for some employers that are going to drop coverage or something like that, but they're actually not expecting a whole lot of that. Because why do employers cover people right now when they don't have to? Part of it that there's a tax incentive, but it's obviously not enough to cover everybody because we still got all these people that work that aren't insured. So why do the rest of them do it? Pardon me? Maybe that, I mean, there is definitely a shift of benefit costs with less salary everywhere, right? I mean, if you look at it, most people don't look, when they look at their paycheck, they just look at what they get in money, if you will, but the benefits is huge, right? At the university, it's about 30% on average of the wage is actually benefits. And so there is some trade-off. But it's actually the same thing that was happening during World War II. It's a recruitment retention issue. Right? The only reason that employers offer it is to recruit and retain employees, and it's not that they're doing it because it's the right thing. I mean, some of them are, but in general, they're not doing it because it's the right thing to do. They're doing it to make widgets, and the way to make the best widgets is to get the best employees, and the way to get and keep the best employees is through offering benefits, right? But if you don't have to, then you're not going to do that, or if you can't afford it, if you can't, if you're a small profit margin kind of company, and a lot of the small businesses and a lot of the uninsured work for smaller businesses. So that's kind of where we're at. But that's why they're not expecting a lot of people who are going to all of a sudden drop coverage when this comes in, because they're not doing it for that reason now, and they're still going to have to compete for workers later. Okay. So what's already in place? There's actually 43 components of the healthcare law that are already in place. And most people are looking sort of at the individual mandate and what's going on in 2014, but this is a really big issue, and this is what the Supreme Court was looking at and what they called severability, and that's what's going to happen if the Supreme Court rules that the individual mandate is unconstitutional. What will happen to all these things that are already in place? And it was really interesting, the day after the Supreme Court heard their last day of hearings, you started seeing all these people that had been publicly opposed to the health care reform law start saying, well, maybe it's not so bad, and maybe we shouldn't throw it all out, and maybe we've been learning some things, and maybe we've been making some steps forward, number of health insurance associations and that kind of stuff. Because if we go back, what are we going to do with all these things that have already gone into place, many of which are fairly popular? One of which some of you might have already benefited from, and that's the ability to be covered on your parents' insurance policies up to age 26. This is one of those low-hanging fruit, very inexpensive, picks up about 2.5 million of the uninsured so far. In Iowa, we were already up to age 25, though. We were already ahead of the game, so we just gained a year out of this. But this was one of the first things went into place that worked pretty well. The second one didn't work, and that's the development of the high-risk pools. And that was the idea, because we weren't getting rid of pre-existing conditions and annual maximums for adults. We did that also early with kids. So what can we help them until 2014? And so these high-risk pools were supposed to help these people that couldn't get insurance or it was going to be too expensive. But what happens? You pool together all the high-risk, high-cost people, and you're left with a pool of high-risk, high-cost people, and even subsidized, the price is still so expensive that it didn't pick up nearly as many people as they thought. So this one just doesn't work very well. But then getting rid of pre-existing conditions for kids. And this gets back to that whole idea that the individual mandate was there for the insurance companies. And I was in a meeting about 2.5 years ago in Des Moines with the CEO from Principal Financial. The same week the Health Insurance Association of America came out and said, we'll support the individual we'll support getting rid of pre-existing conditions and annual maximums and dropping people because of their cost if they do the individual mandate and pool together all of the lower cost people with the higher cost. Because from the insurance perspective, you've got something called moral hazard, that if only the high cost sick people buy insurance, obviously they can't afford it at the same kind of rate as if you've got about half of the uninsured, which really don't use much health care at all and pool them together. And so again, that's what that is. So they agreed with this, got rid of pre-existing condition for kids, and then what happened? Anybody know what happened in Iowa as soon as that went in place? The insurance company stopped selling individual children's policies. So for about 2 or 3 months, you could not buy in the state of Iowa a children's policy because the insurance companies, even though they said at the beginning, and I'm not one of these believers that the insurance companies are the boogeymen people. I think they're doing what our system is sort of designed for them to do to some extent. But this one was a little bit tough, and they had originally agreed that, yes, you pool all these people together, we'll get rid of these things, then they just stopped selling them. And then they kind of had to work through that. And then the other thing, what's called the issue that Colin mentioned about the administrative costs of Medicare and Medicaid being cheaper than private insurance. And so to try to rein in the costs, since we're going to be subsidizing the private insurance through these exchanges a lot, they said, okay, but you're going to have to get your administrative costs to 15 to 20%, depending on what type of company you are. And then this is the coverage, getting rid of coverage because of illness. There's a small business tax credit in there. Again, is it enough to mean something? Maybe, maybe not. But for small businesses, for 2 years, you get a tax credit up to 35% if you purchase insurance. Some review of cost, but there's nothing in here that says, what the cost of the premiums are going to be. And I'm actually of the belief that there's probably too few mandates in this whole thing to make it work rather than too many. The only mandate really is that individual mandate. And now what they're doing is they're giving the states flexibility on everything, which is good to some extent. But now you've got people, again, employers and others that are saying, wait, now we're going to have to deal with all of these different rules and regulations across different states and all of this. And it's like, we want standardization, but we don't. And it's always tough to do this. And then the financing one, and this is just sort of I think a kind of a funny anecdote, again, from Senator Grassley's aide. Well, where the 10% tanning tax? Did you all know that this is in part being financed by a 10% tax on tanning? Really important issue, right? It's really a big deal. According to him, and I don't know if this is true, but he said it was originally a Botox tax, and then you had Speaker Pelosi, you had Minority Leader Boehner, Boehner, Pelosi, from the Botox tax became a tanning tax. Whether it's true or not, I don't know. But that was good. So if it does go through, the interesting thing about the individual mandate, and this is an Urban Institute report, which is you might say a slightly conservative think tank group that came out the same week that the Supreme Court was ruling, the individual mandate is really only going to affect about 6% of the population. If you break down all of who's in what group and who is with this, only about 6% are actually going to be affected by the individual mandate. And most of those people do want insurance. And so, this idea that we're forcing all these people to do something that they don't want to do with the individual mandate isn't actually true. Now, that doesn't mean whether it's constitutional or not. I mean, that's a separate issue. But just in terms of the numbers of people that are really going to be forced to do something that they don't want to do, turns out to be actually pretty small. Again, whether that's right or wrong or whatever, you could argue. There is a large employer mandate for over 50 employees that's going to be coming into play, but 95% of them already offer health insurance to their employees, so it's a relatively small deal. But if you're a McDonald's or an employer like that, it can be a pretty big deal. And that's when you got this whole discussion on mini-med plans and some of that we can talk about. But for the most part, the employer mandate isn't a big part. The big things are these last two, the Medicaid expansion and the health insurance exchange. Okay. So the health insurance exchange, and this is where you're going to go to purchase private insurance if you're not currently insured in a more regulated sense with those provisions about no pre-existing conditions and being dropped and all of those kinds of things. But it's sort of an online Expedia, if you will. So the idea is, you can get online and there's going to be supposedly a bronze, silver, gold, and platinum level of benefits. And then you'll be able to pick which one you want depending on what the cost is. And there'll be different levels of subsidy depending on what your income is to purchase it. between roughly 133 and 400% of poverty. And probably, and all of this is in the works, and state government is working diligently to try to figure out how to put this into play. And I feel very sorry for them and all of the things that they're being asked to do related to this, and it is huge and on a very short timeline. But the idea, you probably are going to have a medical plan, you may have a dental plan, a vision plan, a prescription drug plan, and you can sort of pick across. Where, again, one of the things I'm not sure is going to work is the vision, pharmacy, dental. Those are all going to be, because they're optional for adults, they're mandatory for kids, they're still going to be very much affected by that moral hazard, that people are only going to choose them if they need them. And so like right now, you can't go on buy an individual dental insurance policy, because all they would do is, have you go to the dentist, do an exam, figure out what your treatment plan is, charge you 12% extra for your administrative costs, and this is what we're going to bill you. Now, how that's going to work in this, because, again, it only works by pooling together people who have need but don't have to spread that risk. So there's a lot of these things that we'll kind of see how it's going to work. Then the other component of this is the Medicaid expansion. And so right now, to be eligible for Medicaid, you can't just be poor. You have to be both what's called categorically eligible and poor. So you have to be disabled, or you have to be a pregnant mom, or you have to be a mom. You have to fit, if you're a single adult that's not disabled and just poor and don't have a lot of health care costs, you're not eligible for Medicaid. So they're going to pick up, that's where most of that 16 million that I showed you earlier are going to get picked up in that. So they're going to get rolled into the state Medicaid program. And then from there, then people will go into the exchange. For kids, you'll have both Medicaid, the Children's Health Insurance Program, then the exchange. Okay? So again, real important piece of this is sort of that structure. Does that kind of make sense to folks? Okay. So for adults, again, that's the difference between kids and adults. So kids, you're going to have 133 for Medicaid, up to 300 for the Children's Health Insurance Program, which now is called Hawkeye, and then above, you're going to be going to the exchange. For adults, for the most part, you're just going to have the two. There might be something between 133 and 200%, some sort of a minimum benefits package or something like that. In Iowa, we're already at about 97% from our data at the Public Policy Center. About 97% of kids are covered in Iowa, and about 2/3 of those that aren't are actually eligible for Medicaid or CHIP. But adults, we're at about 9 to 11%. And so that's where we're going to be picking up about 150,000 new people into the Iowa Medicaid program, and then probably about 200 to 250,000 into the private exchanges. Okay. This is where I think it's going to be real challenging. And this is the idea of what it's, we said it's about $15,000 a year for a family policy, and we're not saying that these have to come in lower. Nobody's telling the insurance companies what the price of these products are going to be in the exchange. They're just telling them with that medical loss ratio, that 15 to 20% administrative cost, you've got to control it. But if they just demonstrate that our costs are going up, so next year it's $16,000. Well, even at 100 to 200% of poverty, they're estimating that the cost for the individual is still going to be about $2,000 a year, or $4,000 per family. And as you've seen earlier in this class, when we're talking about what kind of income at that percent poverty, the basic minimum, as we've seen, is really about 220% of poverty just for your basic living expenses, not much else. And so to think that these families are going to have $4,000 of disposable income to purchase it, even with this big subsidy, is questionable. Plus, we're subsidizing the insurance companies for about $11,000 for each of those that they're selling. Again, is that a sustainable model, and is that something that we can do long term? I think there's no question with that. This is the essential benefits package that's being defined, but these are the categories of things. Now, the difference that's just kind of coming out that seemed to be completely lost, and there was a couple stories recently about that during the Supreme Court discussion publicly, is that doesn't mean that these are being covered 100% or they're being covered comprehensively. So, for example, that bronze level plan, they all are going to cover this, but the person might still have to pay 40 to 60% out of pocket. So it still is really going to be just a catastrophic policy. It's going to cover comprehensive things, but it's really a catastrophic policy up to, again, that platinum level where it might cover 90%. And And so, again, you got to be real careful in terms of what that is. And, and prevention is one of those, and, public health thing, we want to cover prevention. But prevention isn't necessarily cheap and doesn't always save money, but it's a public good. But you throw prevention in, again, it's going to increase the cost. So where do you balance those kinds of things? But that's the issue with the coverage versus those levels and how much it's going to cost. Okay. So what's going to affect it to go through? Just real briefly on the Supreme Court issue, and we can talk about this more if you want. And again, I'm not a constitutional scholar, but I've talked to a number of them, and they're, nobody, I don't think, who is serious about it is willing to say the way they think it's going to go. But it's interesting, sort of the way this has come about, and that the focus of the Supreme Court discussion that went on, number one was whether the individual mandate is constitutional or not. It has to do with the Commerce Clause and that idea, can you make someone purchase something? The counter argument is that everybody's already purchasing it, everybody's already in the market, you can't opt out of the health insurance market. And so that idea of whether you're in or not is sort of part of the premise, as I understand it, for that decision. And then that severability, that issue about can it be separated. There's a side issue which is kind of interesting. It goes back to an 1867 law that said that a tax cannot be reviewed by the Supreme Court in advance of it going into place. One of the appeals courts had said that the tax, if you don't have insurance, the penalty is a tax. So the Supreme Court can't rule on this at all. So part of they were hearing is on that. And then 26 states were saying that the cost of the Medicaid expansion is onerous on them, and so that should be unconstitutional. The interesting part of that one is that right now, most states, about 2/3 federal money, 1/3 state money for the Medicaid program, but it's a huge part of the state budget. With this, the first 2 years is going to be 100% federal covered and 90% federal covered afterwards. So the match will actually be higher, but you're still taking on more costs for the program, and nothing says that future Congresses aren't going to change that. And so even though they say it's going to be 100 now and 90, somebody could come in later and say we're going to cut it back down. So as you know, or many of you are probably aware, they spent 6 hours discussing this in public. You could question how much the public debate even means anything or not, but I think it is an indication on how important they think this decision is being viewed, and they wanted to make it seem like they cared about how this decision was, maybe give you some idea of where people were leaning, but it's really hard to say that. With that, I will just say that I think the implementation of this, if it goes through, is critical. Regardless, again, of any complex laws, there's going to be good and bad things that's going to come out of it. I think the issues that we're dealing with are not going to go away. The 50 million uninsured, $3 trillion in costs, all of those things, we're going to have to do something. There's state and federal level implementation, though, that we've got 2,000 pages of the bill, and it's going to be 2 million pages of implementation language at the federal, state, and local level, as Dr. Miller-Meeks is immersed in. And what that is going to do is going to be critical to how well this functions or not, given its current structure. And the cost containment component. Is this going to be enough to hold on costs in a way that are sustainable for our country for the long haul? Hard to say. There's another component about called accountable care organizations. A new component of that just went into place. If we have some time later, we can talk about that. There's a whole different way of delivering care, putting more of the financial burden and risk on the providers. Again, good or bad, but that's part of what's going to be affected that you don't hear a lot about. That could be one of the bigger components. And then if this does go, what are we going to replace it with? What else can we do that's going to cover 32 million people, that's going to do some things to hold down healthcare costs, that's going to be any more effective than what we have here? Big question. Again, is this the panacea? No. But what else could we do that would be any better? So with that, I'm going to turn it over to Dr. Miller-Meeks, and she's going to talk to you about the issues that the Department of Public Health is facing with implementation of healthcare reform and anything else that you, in her perspective and from the administration's perspective. Dr. Miller-Meeks is a very interesting person, I think, in this position, has been a nurse, has been a physician, is an ophthalmologist. So it brings a very interesting perspective to all this. So I also want to thank her very much for coming. She's making 2 trips out of the city just this week alone. And I'll back and forth.
I know I forgot to tell you that I started out couple of things, and because this was fascinating, and as you went through, there's all kinds of points you can talk about, and I'll just talk briefly. Like Justice Scalia, you really don't expect me to read all those 2,700 pages. So the last time I did that was before, as the law was being passed, and I did read all of those pages. First the 1,900, and then the 2,400, and then the 2,700. So I'll talk a little bit about what we're doing at the state level, and then Dr. Damiano wanted me to talk about the Health Information Network, which is a component of healthcare reform, but not truly, it's something that superseded actually the Affordable Care Act. So I have a question to ask you, first of all, and that question is, what's insurance? What's insurance? Why do you purchase insurance?
It's kind of like a safety net.
A safety net for what
For
are you trying to
yourself.
mitigate?
Are you trying to mitigate massive healthcare costs for yourself?
Any kind of health, any kind of insurance. Not health, what's insurance? Just what's insurance? Why you did it? Why do people purchase it?
Just to try and, curb costs of taking on cost of anything that would be outside of your budget.
You're trying to mitigate risk. So you're trying to protect yourself or your family or an institution. If you had flood insurance at the University of Iowa, okay, you're trying to mitigate You're trying to mitigate risk. So you're protecting yourself and your assets against a catastrophe, right? So you would think insurance would be something you use all the time or just sometimes.
Just sometimes.
Okay, so what do we do with health insurance? What is health insurance? We went through the history of insurance and social insurance. Started off, you saw it was just catastrophic to protect people. It was a social insurance policy. It was to protect their assets and protect them against going bankrupt and using all their assets for health care. So you went from something that was protecting you against a catastrophic loss to how do we use insurance today, and you saw the list of essential benefits in the Affordable Care Act. So how do we use health insurance or medical insurance? Are we using it for only those things that are catastrophic?
Not insurance.
So the point I'm making to you, Dr. Damiano said something about critically thinking. So I'm trying to get you to think, what's insurance? And what do we use it for? And then put that into perspective of what you've just seen. So are we talking about insurance, or are we talking about a prepaid benefit plan? Okay. Number two is risk pool. And you heard about risk pool, and often risk pool is a confused terminology. Because risk pool is often said, you get a whole bunch of people together, and they all pool in their money, and then the money goes out. And some people will use more of that revenue for services, and other people will use less, and that's a risk pool. Actually, in the insurance industry, and this goes for your car insurance, your house insurance, and it goes for health insurance the same way, the risk pool is, as you're bringing in people that are going to purchase that product, you get an overview of what their risk is to use that catastrophic insurance. Okay? So, how many of you have auto insurance and have applied for auto insurance or have recently applied? Okay. So what kind of things do they want to know before they will tell you what your premium is or issue you a policy?
Credit score.
Yeah, credit scores are new. Now, they never asked that when I grew up, thank the Lord.
Credit score. Marital status. I mean,
It used to have to be credit, even more important than your credit status, but yes, they do ask your credit report now, which is astounding to me, but there's marketing data that shows why they do that.
driving record.
Your record. So, when I go and they see my lead foot, they jack up my premium. So they want to know how many accidents you were in, how many speeding tickets you have, or running a red light. They want your history. And what else do they want? What's another? Age. And the other thing, sex. Why? Isn't that discriminatory? Okay, guys, stand up. You guys are at risk. I mean, you're risky drivers if you're under age 25. So if you're male under age 25, you're going to pay more in premium. And the reason for that is because males under age 25 get more accidents. So my point in that is the risk pool is actually the insurance company or any company that assesses everybody that is applying for that product to see what's their risk that they're going to utilize this product. And then if they know all of the people that are purchasing that product, then they can assign what the premium is going to be. That's an actuarial database. So that's what the risk pool is. The risk pool isn't everybody in this room, we're going to all get together, we're going to pool our money, and then some of us are going to use more health insurance benefits than others, and some aren't going to use any, and so it's going to all even out. No. That's why when they were talking about having a high risk pool and no pre-existing condition, that's why that's important, and that's why America's Health Insurance Plans and Karen Ignati wanted to say, well, we'll only cover pre-existing conditions if we bring all you young people in because you're not going to be using any health insurance, and so we'll mitigate our loss if there's a mandate to make everybody purchase health insurance. But that means if you're a young person, you're paying for somebody else's coverage who's using much more than benefit. So that's a risk pool. So I want you to understand that a risk pool isn't everybody puts their money into the pool and then some of it goes out to other people so that you're in fact subsidizing. But the risk pool is they're trying to gather together to find out what's your risk of using this product so they can set their premiums. So if you have no pre-existing conditions exemption, how do they know how to set the premiums? So it's a challenge. So risk pool, that's another thing I want to talk about. Number 3, the United States happens to have the highest per capita income as one of the wealthiest countries. So I don't know that it's necessarily a bad thing as the country gets more wealthy that it spends more on healthcare. Then the third thing, and there was a slide with the paddles on it, having done that before, since I'm a Republican, I'm going to say that it's not that the Republicans don't think that healthcare is a problem, they do. What they're concerned about is cost and choice. And already, it's not just House who came out and said that there'll be $340 billion added to the deficit through the Affordable Care Act, but actually the CBO this year said it's $1.7 trillion for the first 10 years, and that's the CBO. And that's because of the CBO has to score the bill the way the bill is formed, and there's some maneuvers they use in scoring it. So there was $500 billion cut for Medicare, used to pay for the other healthcare parts of it. Okay, but yet they're not going to really cut that $500 billion for Medicare, so it was a double counting. The second thing is something that was called the class part of this, which was long-term care insurance. Under the long-term care insurance, and the way it was scored in the bill was that over the first 10-year period, there were 4 years of collecting the premiums for long-term care insurance, but they weren't paying out any benefits. Secretary Kathleen Sebelius, they dropped the class portion from the Affordable Care Act. So they were going to get some revenues in for the long-term care insurance that now is not in the bill. So that changes also the cost of the bill. So that's where some of those cost things come in, and that's where the CBO has rescored that. So then the fourth thing, and I'll try to make this brief, is of the 47 million people that are uninsured in this country, whenever I see that slide, and the AMA has done the same thing, and the AMA, by the way, only represents 17% of the physicians in the country. So when they speak as organized medicine, they're speaking for 17% of the physicians in the country. They're not speaking for 100% of the physicians. But nonetheless, when you see that number, does anybody tell you where those individuals are and who they are? So there are people who have...
The long version of my talk does.
Okay, good. All right, so that was the talk you gave to the caucus up at the State House. I'm going to like to into that one. Usually people don't show what those numbers are, and so Dr. Damiano can say that later. But I think it's important to look at those numbers. One of the things we're doing in the Public Health Department is that we have a grant to get people who are already eligible for CHIP or for Medicaid to actually sign up for the benefits that they're eligible for. So you have a high proportion that are eligible for insurance that aren't covered, young people who have access to insurance but don't choose to have it, and then illegal immigrants. So the population that truly is either high risk, pre-existing conditions, is a very small cadre of that. In Iowa, as Dr. Damiano said, we actually have a high penetrance of insurance, so we cover, our state is about 92% of our population is covered by insurance, and so for our state, cost is a big issue. So it was anticipated that we probably, when I first went into the office and we were talking about the benefit package, it was estimated by Department of Human Services, which is where Medicaid is housed, that we would have 80,000 people that would come onto the Medicaid rolls with the new eligibility criteria. Now that's between 150,000 and 200,000. I think Dr. Damiano said 150,000. So that's a significant cost to the state, and so of course the state is very concerned about that. Now, the way that the state was approaching the Affordable Care Act by legislation, it was put into the Department of Public Health. So the Department of Public Health had the initial planning grant, which was $1 million, and a significant portion of that went to Department of Human Services, or Medicaid, which makes sense since they have a huge portion of it, and because part of the Affordable Care Act has to have a seamless integration between the exchange and Medicaid. And so therefore, since Medicaid has an IT system that's about 30 years old, they call it a legacy system. I think they should term it something else, give it a different name, but they should call it a terminal system. But at any rate, a large portion of what they have to do is to alter their IT system, which you can imagine is very costly, to the tune of $20 to $30 million for their IT system to be upgraded. So a big portion of this went to Medicaid, and then another portion went to the insurance division, and then a portion stayed within the Department of Public Health, and they had focus groups and forums trying to get part of the customer focus of the Affordable Care Act. That's one of the requirements. Late last year, in the September timeframe, we had a visioning session, if you will, with Insurance Division, Medicaid, Department of Public Health, and some of the other players. Some of the staff in the governor's office was there. There were legislators involved, but I don't think any of them came to that meeting. And basically, the consulting group, which has helped other states with what they're doing, went over kind of the skill sets that are needed. And it would not surprise any of you that in Iowa, with the Public Health Department being involved in the health benefit exchange, we're the only state where the Public Health Department is involved in the benefit exchange, because it's an insurance product, and so in most states it's either their Medicaid division or their insurance division that's handling the function of that. So through this consultant, it was determined that it really is the lead agency should be insurance or Medicaid, DHS, and so through that it became insurance and DHS that are the lead agencies. So the Department of Public Health has scaled back a little bit on what we're doing. So currently, we did apply, the Department of Public Health applied for the Level 1 Establishment Grant of the Affordable Care Act. That's $7.7 million. And then they've changed the timeline a little bit for Level 2. You also have to have legislation which allows you to apply for the Level 2 part of the grant. And neither party put forth legislation this year, although we think that the way our current laws exist, the governor would be able to do this through an executive order type thing. I think that's what the train of thought is at this point in time. Of that Level 1 Establishment Grant, that $7.7 million, the majority of that is going to Medicaid. As I said, they have a lot of components that they have to work with for both the new Medicaid eligibility criteria, changing their IT system, the consultant that's helping them with that, for the looking at the navigator component of the Affordable Care Act, the small business or shop portion of that, the essential benefit packages. So they're doing that component. And then the insurance division has hired a consulting firm, David Lynn, which does a lot of the analysis, looking at the marketplace to determine how many we will have that will be under the new eligible criteria for Medicaid, and how many they think will go into the exchange format. So that's basically what's happening at the state level at this point in time. Some of the other states have sent their money back that were early adopter states. To the north, Wisconsin has their philosophy now is they were one of the early innovator states. They returned their money to the federal government, and they have determined that if this is a federal program, then why do we need to administer it as a state? If it's a federal program, it should just be left with the federal government. I think that Wyoming is now doing a similar thing. I was talking to one of our colleagues on a different matter, and they indicated to me that they were not pursuing the benefit exchange in their state either. So that kind of is what's happening at the state level on the health benefit exchange and where we're going. So we are pursuing it. We're not at the point where we could apply for the level 2 establishment grant, but that deadline, which was to be June 30th of this year, has also been extended. And we think that we could proceed onward even without a legislation that's passed through both the House and the Senate, just because of what's already in current law. So that kind of gives you an idea of all of that. So the next thing I want to talk about is the Health Information Network, and I'm going to talk about that because that's kind of a component part, if you will, of the Affordable Care Act, but it actually predates, I think, this current administration, and probably even goes back, actually, probably to Clinton. But
the hope for it, yes.
So it's been a very long process. I think what the Affordable Care Act did was actually put money towards the Office of the National Coordinator to put money to incentive payments to get hospitals and providers to adopt electronic health records. So the process is to get all providers and hospitals to adopt electronic health record, and then the Health Information Exchange on the statewide level. I like to think of it as an airport hub. Actually, information would go into the airport hub when it's requested by an organization that participates, and your health information would then be able to go forward to whoever requests that health information. So for the past, since 2008, the state has been working on a statewide health information exchange. It's been a very diligent process. Last year we put forward a bill which failed. We had an $18 million shortfall in setting up the Health Information Network. We were able to, through a variety of tactics, if you will, make up that shortfall. We've got memorandums of understanding with our largest health systems, are able to fund our Health Information Network, and our bill just passed and the governor signs it tomorrow. So tomorrow the official bill signing will come for the statewide Health Information Network, which will allow you to agree to have your health information transmitted to another provider or another hospital who is requesting your health information in order to provide care to you. Has a variety of benefits, especially if you're looking at our Medicaid population. For a hospital to have a patient come in on Medicaid, to be able to then access their health information data to see, have they been to another hospital, have they had x-rays or tests, can I have those imaging scans or laboratory tests sent to me so we don't duplicate them. I think that's going to be a cost savings that Medicaid would anticipate could be about $1 million per year in avoiding duplication of tests. Storage capacity, not having to have records, having access to information immediately when a patient's being seen, all of those certainly can be a benefit not only to the Medicaid population, to others in the healthcare field. So I know that I was only supposed to talk for about 15 minutes, so I'll talk more if there are questions or concerns. But the Health Information Network is a pretty cool thing, and we're very proud of it getting up and running. So.
Okay, we threw a lot of concepts and a lot of things out. I did want to just comment on a couple of things that Dr. Miller-Meeks said, and one I just mentioned her that I do a whole lecture on that healthcare is not insurance, and health insurance isn't an insurance, and it violates all of the principles of insurance. And if you think about with life insurance, when you buy it and you think about what happens, that because you have insurance, you're not more likely to die, right? Well, what happens with health insurance? What do we know about people with insurance versus people that don't, who are going to use more health care? People with insurance, right? If you have insurance, you're more likely to use something. Again, it gets at that whole moral hazard thing. The predictability, because you insurance, again, your life insurance, you don't know when you're going to die. You have no control over that. With health care, you have control over it. There's a whole series of things that plays into that. It's not. It's both prepaid health care, if you will, and then it also gets into that issue of being a social good, and where you feel how much of a social good it is and how much that's worth, starts getting into this, I think, public discussion in a way that makes it a little bit challenging. The other point I was just going to follow up about who are the uninsured, and that was part of the reason that of that $50 million, and you could argue about the numbers and the exact and this kind of thing, but in general, that's why you're only picking up 32 million of the 50 million, as she was alluding to, because a number of those folks are going to be undocumented, who are not covered in any of these, either public or private components of the law. You've got people who can opt out of it because they'd rather pay the penalty. And so again, it's not comprehensive. But what we do know about the uninsured, a couple of the characteristics, some that I mentioned, but the majority of them, 2/3, are going to be in that 18 to 44 age group. Many of these people are in lower wage jobs, in their first jobs, coming off their parents' policies, things like that. They don't have the type of job or the money to pay for it. As I mentioned, 2/3 of them are going to be making under 200% of poverty, but they are working, 80% are working. In terms of education, 2/3 are going to be a high school grad or less than a high school grad. So again, these folks are not well positioned to get a higher paying job. And one of the things, again, like unions or not, but when we've seen a significant decline in non-public sector unionization, that's where you got the collective bargaining, and that's where the insurance coverage grew post-World War II, because as the economy was growing and you had more unionization at that time and collective bargaining, then you had someone bargaining for you for benefits. That again, and that's not meant that whether that's a good or a bad thing, but that's a factor in the change in insurance coverage. And in terms of race, about half are non-Hispanic white, 14% black, 1/3 other. Health status, 2/3 are reported to be in excellent or very good health. So there, that just kind of gives you a sense of who are those folks, and a little bit about why. I don't know. Did you want to follow up with anything else?
Great. I just want to. I think this question of how you assess and pool and handle the risk is absolutely fundamental. And I think just to go back to a point that I made earlier, one of the points in this historical story at which we did have sort of actuarially sound risk pooling was when General Electric could say to an insurance company, here's 200,000 workers. It was a big enough pool. It was that the insurance company would say, fine, we'll insure them all. Well, you can't do that with 4 guys that make sandwiches at Jimmy John's and say, here's a pool of workers, right? Because it only takes one of them to, run that car off the road and you destroyed your risk pool. Another way of thinking about the pooling of risk, and this goes directly to the predominance of, young people in the uninsurance group, is that one way to think about it is to think about it as pooling risk across your own lifetime. And the United States is very unusual in the sense that we have very well insured 85-year-olds, but very poorly insured 20-year-olds. And if you were able to take a sort of bird's eye view of your own life and decide when you really want good health coverage, you're probably more likely to choose age 20 than age 85. But the system is set up in such a way that people tend to, in larger numbers, sort of drop out of that comprehensive coverage at the time when they're young and healthy, and then look to get back in as they get old and sick.
Well, and the reason why it's important is because it relates to cost. And so having hired people, I can tell you that whereas you indicated that people look for their benefits, the younger people that we hired were not concerned. We had the best retirement package in Ottumwa. So our little business paid a 12% into their retirement fund, and if they would do 3%, we would do another 3% matching that. So with no match, we paid 12% of their salary into retirement, and then we would do another 3% if they put in additional 3%. Now, it was to our benefit to do that, so I'm not going to say that it was wholly altruistic. It's because of the way the law is written, the way the tax laws are in reference to retirement. We were the higher earners in our business, and therefore we wanted to put as much money, and we were also older. We were all in our 40s and 50s, and we wanted to put more money into our insurance, but we also wanted to encourage our employees to do it, so that's why we did it that way. They were less concerned, actually, believe it or not, even with that package, we would have people leave to go work someplace else that paid 50 cents more an hour or $1 more an hour. We also had full coverage with health insurance. So our younger people who did not see themselves at that much risk were less inclined to come into our practice because of benefits, and they were more looking at their salary. So the question is, how do you expend those dollars? And because of the way that the health insurance marketplace is set up, after, you mentioned in World War II when there was wage and price caps, you could offer health insurance as a benefit when you couldn't increase wages. And so that's distorted our marketplace. And the risk pool distorts things also. If you had a nationwide risk pool like you do for auto insurance, it wouldn't matter if you worked at Jimmy John's and there was only 4 of you, or if you worked at GE or IBM and there was 5,000 of you. So that will shift us away from, I think, an employer-based marketplace. I don't know that for a fact, but I would assume that that will alter those dynamics.
Well, let me just comment on that, because I view that actually very differently. That was something that when President Bush had a tax reform commission, the first proposal that they came out with was that the problem, and this is both on the union side, if you will, and on the CEO side, is that tax deductibility for businesses that can write off the benefits, health benefits from their taxes, is unlimited right now. And so it doesn't matter how generous that is, we as taxpayers are subsidizing that to the tune of about $300 billion. So all of us that like to think, well, those people on the public dole are different, than us with private insurance. Well, you're not. You're being subsidized too by the government, but it's unlimited. And so that
and worse is that you have your lowest paid worker is subsidizing higher paid worker.
Exactly, and that's what, or highest paid or highest benefit. So for example, like those union contracts that I was talking about, they had the collective bargaining, but they also were getting maybe too generous of a benefit, but they had somebody bargain. So you kind of had these people that are getting a lot, and then you've got people that are getting nothing because they've got nobody to bargain for them. And so when it came to the politics of this, so what they were trying to say is, we'll subsidize this only to a point, that we want to encourage employers to provide it, but we're only going to subsidize by the taxpayers to so much. But you had the labor on one side and the CEOs on the other, so you had both the Republicans and the Democrats, when this should have been, in my opinion, the first thing they did was to cap what the maximum that we're going to allow for tax deduction. That got pushed off to 2018, 2019, because you had the politics of both sides together on that one. And so it turned into, from what I thought was like the lowest hanging fruit and a fairness thing, to something they couldn't even accomplish.
Yeah, I think you were inferring that perhaps I didn't like it. I think that the tax treatment for health insurance should be the same, whether you're an individual, and you talked about the distortion of the individual marketplace, so whether you're an individual or whether you're a business, it should be the same.
Right. Yeah, and right now it's not.
And it's not.
Yeah. Okay. Questions? Yes.
There's a lot of, kind of rhetoric on both sides about this healthcare. This kind of for everybody on the panel. What do you think is the biggest misconception about the healthcare reform bill as presented in the media? So,
where to start? I think both sides distort it tremendously. The individual mandate is a perfect example, I think, of the distortion. You had the left that it became the panacea. If we did not have but this idea that they were trying to come up with a way to create competition within the exchanges. And the way that they were going to do that was going to have some sort of a government plan that would be in there to oppose the private plans that were going to go into the exchange. Okay, so as I mentioned earlier, when they were setting up how the private plans are going to go in those exchanges, they're not going to say what the cost was going to be. So how do you get the cost held down? The idea is we're going to create some market competition. So the left was saying the only way to do that was to have a Medicare type or a Medicaid type plan in there, and that would create, because of the lower administrative costs and lower reimbursement, but a plan in there would be lower cost and would drive the Wellmarks and other kinds of plans down. The right saw that as the camel's nose under the tent, and this was just the start of a movement towards the national health insurance plan, because it's going to be lower cost, people are going to choose it, you're going to have a lot of people going into it, and then people would be driven toward it. And so that was one of those things that didn't even end up in it, but was distorted from both sides about something that was almost ridiculously simple to some extent and a part of the mechanism that's no longer there. And again, I don't think that was necessarily the right approach, But that idea of how you create some competition in the exchange to keep those prices down, I think, is going to a really big one. And I think that's just one that was distorted both ways. I don't know, what do you...
I would disagree with that because if you set up an exchange, you mandate what benefits are at particular levels, and then you subsidize for those, and you have up to 400% of the federal poverty level, which is about $88,000 for a family of four. I don't see where the insurance companies, and it could be just my lack of knowledge, but I don't see where an insurance company then has any incentive to lower its premiums, and it's still within the state.
Right. We're actually in agreement.
So I think that exchanges, I think, were neither a Republican or a Democrat or a liberal or conservative, whatever title you want to place on it. An exchange could be very beneficial. It could, in fact, offer comparison consumer shopping. So if you have the choice of what you want to cobble together as your benefit package, then that's something that allows you to tailor your costs. So we talked about that people are mandated to have auto insurance. What are you mandated to have in auto insurance? Liability. And are you... So in the healthcare market, the much bargaining power. In our practice, one of the things I instituted there was we actually had, if people paid cash at the time of service, we discounted them 25%. We could do that legally. You can't waive a copay, that's illegal. You cannot waive a deductible, that's illegal because you have a contract with your insurance company. And so if I want to offer a patient a discount, I have to offer that discount to their insurance company. But what we could do is say, if you pay cash, we can discount it, and then they could submit to their insurance company. If their insurance company paid whatever they paid, they may actually get money back that we didn't get, but it saved us the time and overhead and cost of submitting to their insurance company. So, but otherwise, if you're paying cash in the marketplace, there's not a good marketplace, and there's not competition. We know, however, that competition works in healthcare, so that's one thing I would say that most people disagree with on the Republican or conservative side, that competition doesn't work in the healthcare marketplace because we have competition now and all we've seen are prices go up. We don't have true competition in healthcare that's geared to give you value at a price. How do we know it works? I do LASIK. I can tell you it works when it's not an insurance benefit and there's not a guaranteed payment. So, and we know that plastic surgery is the same way. The second thing you asked was, you were asking about what's, now I'm having I'll call it, I used to call it a Perry moment, but now I'll call it a Dr. Damiano moment, so I'll turn it over.
Yeah, no, what I blanked on was that term public option, and that, we actually weren't disagreeing. The public, I don't think that there is competition in the way that it's currently structured. The public option was supposed to create it, and again, on one side it was the perfect thing, on the other side it was evil. I don't think it was either. I don't think it was enough to probably create some competition in it, but I also don't think it would have, most people were going to choose that, and it would have created some sort of a movement towards national health insurance. Again, the numbers I don't think would have been big enough to do that.
He reminded me of the thing, bending the cost curve down, so that was the biggest fabrication. I mean, I'm looking at it as a nurse, a doc, a provider, private practice, academic medicine, military medicine, and as I looked at the bill, it was not going to bring the cost curve down. And there's a variety of reasons for that, but I've never seen the Affordable Care Act as bringing the cost curve down. And to me, the problem is health care costs too much in the United States.
So my question moving away from the actual language of the bill, but more towards the constitutionality of it as being widely debated. So my question is, what happens if it is ruled unconstitutional? Would you see a change in interpretation, definition of the Commerce Clause? But if it is ruled constitutional, will you see more policy being similar to the Affordable Health Care Act being implemented from the federal government?
Yes, no, I think it would be a substantial change in precedent to find that it is unconstitutional. I wouldn't be surprised if they did, but I think it would change our interpretation of the Commerce Clause. Then the question hinges on the question of severability, because it would be the individual mandate that we found unconstitutional. Then the question is, what else in the law stands? And since most of the provisions that Pete described in terms of what insurance companies were being asked to do to erase pre-existing conditions to insure kids up to age 26 was conditional upon that bigger pool, my guess would be that much of it will come down like a house of cards if it's declared unconstitutional. I don't see. I mean, it's a sufficiently peculiar and far-reaching issue that I don't see the court's decision as being a model for any other kind of policy. I don't see any, if it is upheld, I don't see the administration or any administration jumping at the prospect of forcing people to buy all sorts of other stuff.
It's not a winner politically. To make people do something is never a winner politically. I mean, again, they knew that going into this. They put a lot of political capital on the table to back this approach. And again, Dr. Miller-Meeks, as the politician, could speak to that. But I've talked for years. I don't think healthcare is actually a big political winner. I think it's a really tough one. The minute you get into it, it's such a personal issue. It affects everybody. You've got such strong opinions. I think it's just a really tough one.
Well, I would say that if you just looked at the presidential primary process, that the fact that at one point in time Newt Gingrich backed an individual mandate hurt him politically in the primaries. So I would agree that it's not a big winner politically. I can't tell you whether or not it will be struck. I think you can listen to the comments, and I don't particularly like having video and TV in a courtroom because I think it changes the dynamics of what goes on. But I liked listening to the audio of it, and I thought it was fascinating, quite honestly. And to see how the Supreme Court worked, to listen to the arguments, I really thought that was just highly interesting. And there are some who would say that, Justice Kennedy's comments, that since he's the swing, that means it's going to be overturned. I can interpret those comments from the judges in a variety of different ways. So to me, I don't have a good sense. I'd say it's 50-50. I don't know whether or not the individual mandate will be overturned. I think if they do, if you could purchase a catastrophic policy, I'm assuming that you're under 25, you look kind of young, so maybe not, maybe you just look young and you're 35. But, if you could purchase catastrophic insurance at $2,000 a year, but because of the Affordable Care Act, it's going to cost you $12,000 a year, what would you want to do? You'd want $2,000 a year. And there was a great article in the Wall Street Journal from he was a journalist in New York City, and he says, because of the Affordable Care Act, and he happened to say he was a Democrat, not that that matters, because it can be anybody. He said, I've got a policy now that is a catastrophic policy. It costs me $2,000 a year. The Affordable Care Act is going to make me buy Empire Blue, and it'll cost me $13,000 a year. So I think that's a real thing, and you have to look at why are healthcare costs high. When you have a prepaid benefit plan and you can access it any time that you want, what's the incentive to not have people access it? And that's one of the issues on the cost of it. And then you look at why are healthcare costs high in the United States. So
I'm curious about the numbers, or if there are any numbers out there that examine or compare the costs that the government will have to bear for this type of program compared to what they're currently having to cover for the uninsured to go into hospitals and healthcare organizations and aren't able to pay their bills, so those are then written off, have to be written off by the organizations and are covered, by different government agencies. Have some comparisons been done of those two to see, is there going to be a great difference in costs that's actually going to be paid by the government?
The question had to do with, because the uninsured are costing us something right now. That cost shifting that would go on since they'll now be being covered. A part of the reason that the Affordable Care Act isn't going to cost as much as you might think is because what they're going to do is decrease reimbursement rates under Medicare to hospitals with the premise that, well, the government, since Medicare is a government program, we're kicking in through the subsidies to the to what were the uninsured who are now insured, so you're going to have less uncompensated care in the hospital, so we're going to cut your reimbursement. One of the big questions to me, is that really going to go through? When they get to the point that we're going to cut Medicare reimbursement for hospitals, just like when they were going to cut reimbursement rates to physicians 23 years ago, I think is when it first started, 2%, and that can has been kicked down the road, and now it's like 27% if it was going to get cut, and they're never going to do that. But that's what some of that premise is. The bigger point to your question, though, is that we don't have a healthcare system so that those costs are going to be sort of evenly shifted. As President Bush is Secretary of Health and Human Services, we have a bunch of healthcare sectors. And so it makes it very difficult to say, well, because we're going to shift these dollars over here, that these people will save or the government will save. There will be some cost savings and there will be some cost shifting, but the person that benefits or the entity that benefits isn't always that clear. It's just like sort of the thing about keeping somebody out of a nursing home. You know, it might be cheaper to keep somebody out of a nursing home, but cheaper to who? And, you know, it might be cheaper to Medicaid because Medicaid might have picked that person up, but it might be higher to Medicare that might pick up some home health costs or something. And so it gets much, much more complicated, unfortunately, than just to say, well, we're going to save these dollars here, so it's a good thing to do. Because the people that are going to pay more somewhere can give you pushback.
I don't think it's that complicated.
Well,
I mean, I think the proof is in the pudding that there are other rich countries that provide universal coverage for half on a per capita basis of what we spend.
Well, but again, if we had a national health insurance system and everything was together, I think you could make that argument that those dollars would like save the deficit or save the government money, which was what her question was, as I would think about it. Now, it doesn't, if you think of this whole thing as some social good, yes, I think that's true. But because we don't pay in these discrete, or in this whole, we have all these different discrete pots of money, I think it becomes it's harder to say that.
Yeah, that's fair.
I would say I don't know the answer to the question, but I think costs will go up. So I think the overall pot of money that we currently spend on healthcare will be higher. One, you continue to ratchet down reimbursement, which I would disagree with Dr. Damiano. I can tell you that the most common procedure I did as an ophthalmologist, which would be cataract surgery, that I was paid less every single year. So despite the doctor fix, as you call it, I was paid less every year for surgery. So when I graduated medical school, they reimbursed cataract surgery at $2,400 per eye. When I left practice, it was below $584 per eye. And that's in Iowa because of the way the formula is for Medicare, the RBRVS formula. So there may be other things that were going up and costs that were being shifted in order to reimburse primary care more, but there were other areas that are reimbursed less. So they'll continue to reimburse less care.
I mean, one way to look at it is to assume that there are two options for running a relatively efficient and a cost-basis healthcare system. One that I think is proven in a number of national settings, and another would be a fundamentally competitive system based on individual responsibility and individual purchase, with tax advantages for individuals' purchases of health insurance rather than for employee groups. And so if you assume that either one of those would work in terms of bringing costs down, then I think what you're left with is the recognition that we're nowhere near either, and we're stuck with a combination or a hybrid, which is guaranteed to ratchet costs up.
My question's about work reform. Do you think lawsuits have played a big part in driving up the cost of medicine in this country?
So even if you lose a lawsuit, you don't have to compensate the party that wins for the costs that they've incurred. You can have a frivolous lawsuit, but let me also say that when there truly is negligence and malpractice, people So I think first and foremost, that should occur. Unfortunately, a lot of what happens in medicine are outcomes that are not desirable, but there may not be negligence. And so I think that Rand estimated it at $60 billion over the 10-year period. So not $60 billion per year, but $60 billion over a 10-year period. But yes, I do think that drives up the cost of health care in the United States.
And I think it's important to recognize that the actual cost of doctors also have to factor in the degree to which practitioners engage in defensive medicine, engage in a battery of tests that might not always be necessary in order to cover their bases and protect themselves against litigation.
I never like that they're not necessary because it sounds like they're just doing them willy-nilly. There can be an indication to do things, but they do things because they're looking at, how do we make sure that it's not this thing for which somebody could sue.
Briefly mentioned this, but if everything is passed in June, what are some of the direct effects that physicians, current and future, will experience?
I think if we continue to have a medical education system that, between undergraduate and medical school at a cost where people come out of medical school with $150,000 to $200,000 in school loans, that you'll see less people going into medicine. So I do think it changes some of the dynamics. Ultimately, where the system will go, it really depends upon where the system goes and what occurs.
I think the aspects of it that are going to change things the most are not the things we've been talking about. I don't think the health insurance exchange or the Medicaid expansion is necessarily going to affect things that much. The thing that I think will are things that are probably going to happen regardless of about what the Supreme Court ruling is, and that's the thing I alluded to earlier with the accountable care organizations and some of the changes that are already underway, electronic health records. That's a huge change for a lot of practitioners, especially older physicians, if you've talked to them. There's a number of things right now that I think are changing the practice of medicine and dentistry and other things. Electronic health records are huge. In some ways, they're great, but in other ways, they're adding 2, 3, 4 hours onto some people's workday. That's a huge change. It improves the quality of care and the note-taking, the record-keeping, all that kind of stuff, but it adds a burden. Personally, I think part of the burden is also the lack of the system that we have on practitioners, because you've got all these multiple insurance companies with multiple formularies in terms of what kinds of things they can prescribe. What are the quality measures that they're required to submit on? How do their systems match? That is getting to be a huge burden, an administrative burden on practitioners. And that's where I would see, and I've not been this huge proponent for single payer or anything like that, but that's where I would see this whole thing shifting in that direction. To me, what's going to drive it is when practitioners are tired of having this system with all of these different people telling them what to do and are willing to take the chance that, yes, it probably will be a little lower reimbursement and it's going to be a Medicare-like reimbursement or some of those things, but give me one formulary, give me one electronic health record system, give me one set of outcomes that I've got to submit to. And if we get to that point, I think that's what this can be. That's a huge burden. But the accountable care organizations, this is a new attempt at HMOs or PPOs or IPAs or whatever you want to call it. And what this is going to be, and the CMS today just announced a new set of these ACOs, or what they called. There was first a group of 7 that were called Pioneer ACOs. There's one of them in Fort Dodge. Now there's a new group that I don't believe there are any in Iowa. But the idea is that you're going to ask, like an Iowa health system, which is a whole group of hospitals and physician practices and an organized delivery system, that they're now going to be responsible for this population of people, and the financial burden is now going to be on them to some extent. We're in a fee-for-service environment. The provider is not at financial risk in that the more they do, the more they get paid. In a capitated environment, and this is not a new idea, this is going back to the 20s, but the idea is that you get paid so much per person per month regardless of what they need. And so that was sort of one of the original ideas towards wellness, that if you can keep your population of people healthier, your costs for that population are going to be lower and the provider will make more money. The downside, of course, is that it also means the less you do, the more you're going to make. So in a fee-for-service environment, from a strictly cost perspective, the more you do, the more you make. In this, the less you do, the more you make. And so I don't think we know how to use the financial incentives necessarily to drive the right amount. But this is something that could be hugely frustrating, burdensome, unwieldy, especially in a place like Iowa. You know, if you're in Minneapolis and you've got sort of discrete health systems that are unique, know how to sort of compete against each other and kind of do this. But in Iowa, you've got practitioners that are in all of these different systems already. And so they're kind of competing against themselves, and it's going to be a real challenge.
Well, the Medicaid reimbursement is going to drive physicians to drop Medicaid. And we already see that with Medicare. So Medicaid pays at a lower rate than Medicare. Medicare pays at a lower rate than private insurance, and even at the usual and customary rate. So I do think you'll find, unless providers are forced to accept Medicaid, that there will be some that either just drop out or they just retire early, because you have an overhead cost that's relatively fixed if you're paying your rent. So it goes back to competition will bring healthcare costs down. And I said, to me, the biggest fallacy that you hear on one side is that we're creating competition. You're not creating competition, you'll actually create consolidation. The ACO, or the Accountable Care Organization, it is very much akin to a health maintenance organization or an HMO, so you're capitated to cover a certain amount of lives. Currently, it's 5,000. They are doing a model of that in Fort Dodge. And what I really think is kind of fascinating and interesting about what's happening in Fort Dodge and the current version of an HMO, if you will, is that there is population-based. So what's going on in Fort Dodge with Iowa Health System is, since they own most of the providers and they have the hospital system, they're actually collaborating with their public health agency. And many of the public health agencies have home care aid, have homemakers aid, and have visiting nurses. So they get this armor component of population-based health care as well, prevention messaging, community health care. So they're working with their hospice, their mental health, their community mental health center, their federally qualified health care center. So the entire framework of health care will be an accountable care organization in Fort Dodge. And it'll be really interesting to see what happens. I know Murphy is looking at accountable care organization as well as IHS, and IHS is the Fort Dodge model. So,
right. And the other thing that's also changing is that 60 to 70% of physicians now are employees, which is a big change just in the last 15 years.
Goes back to driving consolidation.
In a nutshell, the question is not will physicians face threats to their autonomy from third parties. It's who the third parties are. And, whether it's a government agency that's setting reimbursement rates or capitation or, diagnostic procedures, or whether it's an insurance company doing the same thing. But that's certainly, that was the discovery of the AMA in the 1980s. Well, we kept the state at bay, and now we have Prudential. And it was out of the frying pan into the flame.
And one last part, I think you're going to see competition between physicians, because that's one of the things that makes the United States very different than every other country in the world, is that we're 80% specialists and 20% primary care physicians. Most other countries are the complete reverse. They're 80% primary care, 20% physicians. The specialists, no offense, are the ones that primarily drive the procedures and drive the costs. And when the organized delivery systems have calculated how many different types of specialists they need per population, and in many places we have way too many. And so if this does happen, and you're already seeing it in certain markets, then you start seeing cardiologists that are starting to do primary care, or you start seeing other things, because you've got physicians that are used to making a certain income, and the specialists in general make many, many times sometimes the income that a primary care physician, but yet we want this new medical home model of care delivery, and sort of in what we're talking about, and what Dr. Miller-Meeks was talking about, we call a health home, which goes beyond just the physician's office and gets into all of these other types of providers, which is really what you want. But then who's going to do the primary care? And who are going to be the primary care providers? And that's, again, I think, going to be a huge issue.
So David Sedaris had a recent article in the New York Times about his experience with socialized healthcare in France, and it was generally favorable. But one of the striking differences was he went in and he had like a fatty mass on his side. He thought it was a tumor. And he goes to the doctor just says, oh, that's a fatty mass. It's not benign. There's no reason to operate. You're Native American. And so he leaves. The striking difference.
I just heard the Native American part, I'm sorry.
The striking difference is, there's a reasonable expectation if somebody, was the same situation in an American healthcare system, they would run him through a battery of tests, since he's a insured person. That might happen as a way to drive up costs and make money. Is that a real threat, or is that not?
I would just say, based on my personal experience, I'm Canadian, in case you haven't figured out, and so I have a fair amount of experience with that system. First of all, I think, it's sort of ridiculous to do the Michael Moore game and compare the U.S. to Cuba, right, and say, it doesn't cost anything, it's great. But I think you can compare rich countries to rich countries. And it is true in France, in Canada, in Germany, and other settings like that, that a chunk of the savings comes from much sparer basic care. Part of it is the province of family practitioners who just play that gateway function and never get you to see the specialist. Part of it is just you go to a doctor's office or a hospital in Canada, and it's sort of like going to the garage. Like, when my first child was born in a Vancouver hospital, if it was born if I was fully insured and it was born in an American hospital, there'd be a birthing suite and, all these machines going, they're probably not even plugged into anything. But, we were in this dank little tiled room and, my wife was throwing up and I said, what can I do? And the nurse said, there's ice in the fridge, And that was about it. The bottom line was it was good care, she was safe, but no frills. And I think, that is a big difference between the systems.
We've probably got time for maybe 2 questions. That's anybody else who has not asked a question? Yep.
This is more historical-based question. So probably more Professor Gordon's discussion. But progressive era, as we've shown in one of the readings, was a lot of the issues that, like child labor laws and those sorts of government regulations all ended up passing. But universal health care is also on the table with member relations to make that leap into actually becoming passed through legislation. Why? What about the American system made it so difficult for that particular issue since the beginning of the 20th century?
It's important not to exaggerate how much was accomplished. People were talking about a lot, but in fact, even child labor didn't really make it, fully to the legislative stage. Part of the problem prior to the New Deal, was the Commerce Clause restriction, right? These were understood to be state responsibilities. And one of the big disadvantages, or one of the big drags on doing it at the state level is, if you pass universal health insurance in New York, everyone from New Jersey is going to come get health care there. So they were state-level solutions, and that was a real problem because you'd have to replicate it among all the different states. And they were also in the sort of larger discussion of sort of progressive era reforms. They were understood to be industrial working men systems. So they didn't pretend to cover farm workers or domestic workers. In fact, the bulk of workers in the economy. It was understood to be a specific risk, more like workers' compensation than like what today we think of it. What was interesting about the progressive era is the doctors were for it, and the insurance companies were dead against it, even though not a single insurance company wrote what we would call a health insurance policy. Most of what they wrote was called burial insurance, which paid for the coffin, but they didn't want the government to get its hands on that.
One more question.
You talked about, you said on the one hand we've got single payer, and on the other could be tax credits and health savings accounts or whatever that would be.
Mm-hmm.
We're in the middle, but what's the advantage or disadvantage, or is it possible to do the tax credit, health savings account, things like that? Is that a possibility?
I mean, I think it is a possibility. People have talked about it. I don't think that, I think I disagree with Dr. Meeks about the potential for competition at ultimately bringing costs down to where you see real savings. Healthcare market is a very peculiar market. I mean, it's, consumers are ill-informed. Most of the decisions are controlled by third parties, whether they're, doctors or insurers. And so, I think I'm more skeptical about the potential for competition driving down costs. But I do think, in terms of overall efficiencies, we'd be better off at the sort of than which is just a recipe for nightmarish, spiraling healthcare inflation and a dismal future for everybody.
I'd respectfully disagree.
And maybe you disagree with this, I think the challenge is how do you take it from where it is now to, and this is true with so many things, make it scalable to actually affect any large proportion of the 50 million of the uninsured. I think that's, to me, is a real challenge of the cross-state line competition or the health savings accounts kinds of idea, and particularly if you think of where our healthcare costs are. Of that $3 trillion, the errant physician visit that you might not need, isn't where we're spending our money. It's the big ticket stuff. It's the end-of-life stuff that we don't know is end-of-life going into that last 6 years. It's the chronic disease things, the diabetes, the asthma, those kinds of really big-ticket stuff, and the trauma, and the motor vehicle accidents and gun injuries, and all those things. If you look at the top 10 causes of either morbidity, mortality, or cost, that I don't think those things do address or can. To be honest, I don't think we know how to do that, because that's related to behavior change, and that's related to our, how do we get at obesity? How do we get at nutrition? How do we get at, that 50% of our health that's affected by our behavior? And I don't think any of these things address it very well myself, and I don't think we know how to do it. But I don't know, what do you...
I think the big ticket items, and I think that's what scares people to change the system, and what drives people towards a single payer system. And the amount of administrative cost is another thing. Well, the administrative costs are lower in Medicare, so therefore we should do that rather than an insurance marketplace. And let me just say that insurance companies aren't physicians' favorite people. At all. We certainly have our challenges with insurance companies, and sometimes we hate them. But none.
One of the real challenges here for the U.S. is timing. Every country that went to a more a health system of some description did so at a time when healthcare costs were not that high, in terms of the cost of delivering care. So, the latest I think was Canada, which fully went in about 1968 in terms of the provincial system. So in some respects, we missed the boat on single payer because it'd be very difficult to get there now. But I think you could also say, it'd be very difficult having grown accustomed to a sort of first dollar fee-for-service system to retreat from that. Because you're talking about 20% of the economy.
And the income that physicians have gained because of that.
Physicians are going to lose income regardless of which way we go.
Right.
You know, in one way, they have some control. They can reduce overhead costs by not having all the insurance companies if you went to a health savings model. So some of the administrative hassles would be reduced on providers if you went in that model, or if you went to a single payer. Either way, it would reduce some of that administrative cost, but under a single payer system, then you've got a different regulatory burden that comes into play. So I think either one of those systems would reduce some of that administrative burden that's a challenge to physicians. The other thing that usually comes in under the health savings account, if you went to that type of model, or, you know, you often it's, and I'll say this because I'm in public health, often people will say, well, no one will get their preventative care because they won't want to spend money out of their account. If the account is set up so that, number one, there's guaranteed insurability, so you're not dropped from your insurance if it's a private insurance marketplace. You're not dropped if you get sick. That has to be one of the components. And it can be something that you pay a small premium for. We do that with life insurance or other types of insurance. Number two, if the money rolls over to your account so that your account is expanding when you get to the higher expense items, then people have a vested interest. The incentive is there to do prevention. So the incentive is there. If that money is in your account and it's yours, okay, and it's used, why didn't I take it? Well, because I figured out how much it was going to cost me per month, how much I spent in my dental, you know, and I said, well, it's going to cost me more to buy the insurance that I would spend in a year, so I just need to save the money aside. Hard for people to save money, but I do think that people can be educated, they can be informed, and what I've seen in practice in the past 8 years with the advent of the internet, people are coming in to see doctors more well-informed and can be a pain in the tush, because they're bringing in all this stuff they downloaded off the internet and printed out, and they want you to talk about all this stuff, and like none of those diseases have anything to do with what they're coming in there for. A hypochondriac, and so they always have some new disease, but they don't really have a new disease until they really have a disease, of course. But, you know, you have people coming in with reams of information, wanting to have, you know, someone go through that and explain to them why it's not these things. And typically, you know, physicians, nurse practitioners, you're actually going through all of this in your mind as you're seeing a patient, as you're asking questions. So you're actually going through that differential and why it could be this disease, why you're going to go down this. And I think the same is true in dentistry. You do the same kind of thing. It's actually a mental process that you go through.
Do differential diagnosis, right?
Yeah.